Good afternoon, everyone. Thanks so much, Kate. I'm coming to you from Waseca, Minnesota, in the southern part of the state. Hope it's as beautiful outside as it is here. And hopefully, after this webinar, you can all get outside and enjoy the weather. But it's great doing this interconnected series. This is, I like to call it season two of starting off. We're hoping to have a couple more discussions here in the future as well. And what the reason that this whole interconnected series got started is over the last few years, coming to realize people talk about the rural urban divide. And there might be a divide, but there's also a lot in common as well. And so finding these topics where we have commonality is really important. And so with EMS, there's a lot of questions. When you call 911, you just assume somebody's going to show up. And I know for me in a very rural farming area, I know who's going to show up, but it's going to be a volunteer and it might be a half hour. Where if you're in St. Paul, Minneapolis, maybe it's 5 or 10 minutes. But how is all that structured and what are those policy issues? And so the Center for Rural Policy and Development, I'm the president of that. And we do research on rural Minnesota issues like EMS, like healthcare access, because like Kate had mentioned earlier, policy looks different depending upon where you're at. It is very nuanced. What might work in Mankato might not work in Thief River Falls. And so when we do our research, we try to look at that as a whole, greater Minnesota, and how policy can be impacted by our research so that there's non-biased, nonpartisan information out there. And we are also a nonprofit, just like Citizens League. We're happy to be strictly nonpartisan, like I said, and happy to bring these topics to the forefront so that people across the state and across the country can become aware. Our big goal is that you will take away from this webinar that, oh, wow, this EMS there's challenges there and there's opportunities. What can we do to help? What can we do to make it better? And so I'll just mention that our website is ruralmn.org. And yep, for Citizens League, it's citizensleague.org. And this webinar will be posted on our YouTube channel, the Center for Rural Policy and Development, and that will be posted probably on Monday. But you can also sign up for our newsletter by going to our website to stay in touch with us. So with that, we're going to jump right in because I know we have active discussion. I know I have a lot to learn from our panelists today, but I am going to introduce Dylan Ferguson, if Dylan wants to come on. And Dylan, why don't you introduce yourself and give us that 30,000 foot view of EMS in Minnesota?
Well, good afternoon, everybody. As Julie said, my name is Dylan Ferguson. I serve as the new executive director for the Minnesota Emergency Medical Services Regulatory Board. And my goal here to kind of just get us started is, once me and Anne and Kelly and Mark, once we get talking, we really get into, sometimes we get into the weeds, a lot of acronyms and a lot of inside baseball, as I like to call it. So what I want to do is just provide a very broad overview of Minnesota's EMS system. So overall, throughout the state, we have 200, about 250 different organizations which provide ambulance service across the state. That includes Metro, Greater Minnesota, all of them together. Now, each of these groups looks a little bit different, and that's because when EMS first started here in Minnesota, and as the case with many other states, it was an inherently local kind of bottom up approach, if you will. So when we look at EMS across the state and even within the same county, there are some services which are operated by Minnesota cities and different municipalities. Some of those fall within fire departments. Some of those services or agencies, we use the term kind of interchangeably, are not for profit corporations. Minnesota has a significant amount of hospital based EMS that is owned and operated by some of the few remaining community hospitals, and in other instances by the larger healthcare systems throughout our state. And then also, there's a very small handful of for-profit companies that provide EMS in some corners of the state. Now, each of those services can really have its workforce provided in one of three different categories. So we have services and agencies, which are 100% exclusively volunteer, meaning that those individuals they do not receive funding for they don't receive pay for the work that they do, or perhaps they receive a small stipend to kind of help them cover expenses. Then we have organizations which are staffed by paid providers, where that's their primary job and that's their primary source of livelihood. And then there is a third group of organizations, and we're starting to see this type of organization pop up more and more across the state. And they're what we refer to as combination services. So, in these combination services, as you've probably been able to figure out so far, they will be staffed. Those ambulances will be manned by a combination of some individuals that are paid and other individuals which are exclusively volunteer. In some areas of outstate and greater Minnesota, what we're seeing that maybe these services are relying on a paid person, Monday through Friday during the day, when everybody else has to go to work, but still covering their ambulance with volunteers on nights and weekends. So ultimately, it's the responsibility of the Emergency Medical Services Regulatory Board. We license each of these organizations, but we also are responsible for certifying the approximately 30,000 different individual first responders, emergency medical technicians, and paramedics throughout all of Minnesota. And ultimately, services are supported not only by the EMSRB, but at a more local or regional level by one of 8 regional EMS systems that we have that are spread across the state. One of our panelists, Ann Jensen, today, in addition to some of her other EMS responsibilities, serves as the director as one of those regional systems. So we'll be able to hear a little bit of a perspective from what those regional programs and those regional systems can look like. And I think the last kind of item that I will try to hit on this 64,000-foot tour is that it's important to remember that not every single ambulance is equipped the same or has the same level of capability. So this is where we like to go into acronyms a lot. So predominantly, there are two different levels of ambulance service here in Minnesota. We have basic life support ambulance, or BLS, and those are organizations and ambulance where they have the capability to provide transportation and to provide immediate life stabilizing care. They are, a little bit more limited in the procedures that they can perform or the medications that they can give, but ultimately are the backbone of the entire Minnesota EMS system. And then we have another group of ambulances referred to as advanced life support, or ALS. And these units are staffed by paramedics. And these paramedics, have the ability to give anywhere from, 60 to 100 different medications. They can provide, very invasive procedures such as placing breathing tubes, starting IVs, and really doing a lot of things. So that is a little bit of a highlight of the Minnesota EMS system overall, and very much looking forward to the conversation. But to get us to the kind of discussion of the issues that both the Metro and Greater Minnesota face, I'm going to turn it over to Kelly Ash, who is going to provide us an overview related to some of the research that he has been taking specific to rural EMS. Kelly, take it away.
Yeah. Thanks, Dalen. Appreciate it. Appreciate kind of providing that framework. We're going to scaffold this just a bit more. This is based on some research we did this last spring, released, I think in April, if I remember right, taking a look at rural EMS in particular. But we're going to also provide some context that really kind of talks about metro EMS as well. The purpose of our research last spring was to, one, synthesize the challenges first facing rural EMS. There's been a lot written about the challenges facing rural EMS, and we just kind of wanted to synthesize that for legislators. And then two, identify some priorities for state investment. Like if we're going to take that next step, what might be some ideas and how we take those next steps in terms of investments. Research methods is our typical with, we do a lit review, we did interviews on the ground with agencies, and then we did some cross tabulations of survey data. And that particular survey was actually developed by the Minnesota Department of Health back in 2016. They did this great survey. They sent it out to every EMS agency outside of the 7-county metro, because it was really kind of like getting the temperature on rural EMS agencies. And they had 5 different sections to that. So they had a bunch of questions for each section. 1, the characteristics of the agency. 2, the workforce and staffing issues. 3, agency leadership and financial management. 4, medical direction. 5, community relations. They analyzed this at kind of like a bigger level, just lumped everybody together and did summary statistics. And it was a really helpful, very cool survey. We just wanted to take that and do some cross tabulations because, as Julie said, we're pretty interested in a lot of the nuance, right? So kind of like the EMS in the area of Alexandria is probably facing a very different situation than where I'm at here in New London, Minnesota. It's worth mentioning I'm a city council member here in New London, and the city actually owns its ambulance here. It's a town of 1,400 people, but our service area is probably about 5,000. And it's really interesting. We're in between Paynesville and Wilmer, and those ambulance agencies are owned by Centricare. So very, very cool dynamics, and it's cool to see this on the ground. So anyway, just a crosstab example of what we're talking about. So one question that was asked was, what is the estimated total population you serve? This was, a question that the agencies had to answer. And they said, well, less than 2,500, in between 2,500, 5,000, 5,500, right? Like you got these different kind of bins of population. What we want to do with the crosstabs was determine if an agency served less than 2,500, did they by chance answer or respond at a different rate to this question? Is your agency owned, managed, or receive support from a corporate health system? Do you have enough people to cover your call schedule without undue burden or excessive time commitments? These types of crosstabs can help us identify what are some of the kind of major linchpins in terms of how these questions are answered and what the issues are at hand, but also in terms of like what types of investments, because maybe there's some answers in there too. So today's journey, we're just going to do a real quick context of rural EMS. So Dylan kind of provided the Minnesota stuff. I wanted to give a little bit of history and how we got to where we are to modern day EMS and where I think the medical community and the EMS community is looking in terms of its future. We're going to talk about real quick three key themes that came out of our research and then the recommendations. This will be relatively quick. So history. I think a lot of people, I was surprised when I learned more about this, and maybe we have a lot of EMS agency people that are listening today that know this, but modern day EMS is relatively new. Looking at the literature, a lot of like American EMS originated in the Civil War, right? Trying to get soldiers off the battlefields to get medical attention. Once the Civil War ended, a lot of the folks that were involved in that went back into their own communities and kind of started their own EMS agency in their communities to do that sort of work. By the 1920s, the American Red Cross was getting involved, developed training. We had further advancements in World War II. And it was really interesting between around the 1930s and 40s, most EMS was actually handled by our funeral homes. They had the hearses, and so they could fit patients in there and haul them to a medical service that was nearby. And then 1960s, huge medical advancements, health advancements. We had development of CPR and portable defibrillators. And during the 1960s and 1970s, as the federal government was really looking at what are some of the big health crises facing the American public? One of the big things that came up was car accidents, vehicle accidents, right? Like people getting stuck on the road, not having appropriate service at the scene in order to help folks. And so interestingly, major investments in the development of modern day EMS that occurred during the 1970s actually came from the Department of Transportation, not the Department of Health. Kind of an interesting little fact, but it also sets the stage of like why today we carry on modern day EMS, and we really view it, or at least fund it, as if it's a transportation service rather than a medical service. And you'll kind of hear that, I think, frequently throughout the discussion today, is like, we're still trying to get away from that. The expectations are that it's a medical service, but yet we're funding it as if it's a transportation service. And so that'll be kind of up for discussion today. And then in the 1980s and since, federal government has essentially not provided a ton of support for any further development of EMS. Those 1970 support really got it on the ground in our states throughout the country. And since then, it's kind of stopped, and it's been left up to the states to figure out how they want to move forward. So what's the next step? When reading literature and doing our interviews, there really is this, we want to go from reactive to a proactive service. So reactive means it's a transportation service. So isolated from other health services, reacts to acute illness and injury, financed for service to individuals. Where we want to get to, and I think where things are heading to, is a more proactive type of EMS system, integrated with the healthcare system. Acts to, and that doesn't mean it's owned by the healthcare systems, but rather they work together in providing medical services. Acts to promote community health and funded for service to the community. So essentially, from a transportation service to a healthcare service. So what does that mean in revenue and sustainability? So it's the difference between being an essential service versus a transportation service. Right now, our EMS agencies, what we expect and where we want them to go is, one, they must be 24-hour ready. They need to answer every 911 call that gets called to them. Otherwise, they lose their license. There cannot be examples of that happening. They cannot reject a service based on ability to pay. And there's a lot of training and regulations in terms of how your staff should be set up in terms of their training and their knowledge and the services that they can provide. However, we don't pay them to do this. We do not pay our EMS agencies to be 24-hour ready. We pay them as if they're a transportation service. They get reimbursed if only transporting a patient, and reimbursement rates are actually still pretty low. We'll talk a little bit about that, but I want to provide one example, reimbursed if only transporting a patient. As many of you probably know, as medical health service providers, some of the larger kind of healthcare systems come in and they kind of are starting to purchase a lot of our smaller clinics, maybe taken away, or some of the healthcare services are being maybe siphoned off into the larger systems. That means if a patient is at a hospital and needs to be transported, let's say Ann Jensen has somebody in Dawson, needs to transport that patient to Sioux Falls, many times they'll get paid for that going from Dawson to Sioux Falls, but since they don't have a patient coming back with them, those miles aren't reimbursed. So there's examples of that happening in our system yet that need to be changed. So from a rural perspective, the biggest nemesis is what we always call the economies of scale, right? It seems like every presentation or research we do, this is kind of like the big overarching theme, is the economies of scale do not work out so that this business can function well. We, as I said, expect them to be 24-hour ready, which means they have high overhead. They have to have all the equipment. They have to have the ambulance. Actually, in New London, I know our agency is working on buying a 4-wheel drive ambulance. I think it's somewhere in the neighborhood of $300,000. And so we need to have all this equipment, all these people trained up, but we don't have a ton of call volume to help pay for those things. So we don't get paid to be 24-hour ready. We just get paid for the relatively low call volume or even moderate call volume that just doesn't have the revenue attached to it to do this well. And it's a challenging financial environment in rural areas. We have larger geographic spaces with fewer people, higher percentage of people on fixed incomes. We have a higher percentage of people on Medicare and Medicaid, which generally, you talk to anyone in the medical health industry, they'll say it just does not reimburse at the level needed to actually supply the service. And a higher percentage of people with high deductibles, meaning they might be on MNsure or something with a high deductible. And if it's January and the ambulance gets called out, they have to foot the bill for the ambulance, and that deductible might be quite high. And so payments might be lacking. Some of the more typical issues that we typically see in rural EMS is more reliance on volunteers, as Dylan kind of mentioned, less likely to have a professionally trained manager. Usually it's the person that kind of raises their hand at the meeting. And thank goodness we have those folks, we need them, but at the same time, are they skilled up enough to actually do the job that's required and not burden them so much as a volunteer to get things done? Staff volunteer recruitment and retention, and more likely to offer basic life service rather than advanced life support. So we're going to just dive in here a little bit and talk about what are some of the key themes in terms of investments or that we would like to see. And of course, support for changes to funding are welcome, right? Make it rain. EMS needs more money. There's no doubt about it. But how do we prioritize in that in a way that really gets EMS moving forward and into the future? And these are the three themes we found in our research. How do we support our agencies to be supported to be professionally managed? What kinds agencies need to be supported to find ways for collaboration and or consolidation, and a more nuanced approach to developing policies and support systems. I'm going to run through these real quick. We're going to start with professional management and sustainability. So we did that breakdown of, okay, an agency that serves a pretty small population, less than 2,500, only about 38% of those agencies have a manager that's been formally trained, either in leadership or business administration or something like that. And as you can see, as the larger the population served, it increases where 15,000 or greater is about 100% of the agencies have a professionally trained manager. When we went in the interview, we started to realize that, yeah, having somebody professionally trained really does make a lot of sense and probably could help just through the interviews. The role has grown significantly in complexity. It's crucial. It's just like operating any other business. There needs to be someone that understands EMS, the financial pieces, the regulatory pieces, and how to handle staffing. And so we kind of mapped it out this way, right? So these are businesses and nonprofits. So they have to figure out licensing. They have to keep track of staff training requirements. They have to navigate the philanthropic ecosystem and write those grants. They have to organize fundraisers in their regions. They have to manage personnel, not only the personnel they have, but also how to go out there and recruit more staff. Those require certain strategies. And then they have to have experience with healthcare services and have relationships with those healthcare services nearby, and also probably provide medical services themselves because they're going to be on call. This is what we're asking from an agency manager in modern day EMS. When we did the crosstabs, this is just an example. There were many examples in which having a professionally trained manager, the responses looked, I would say, more positive. And let me just say that, like, the system itself is great, but the way we have it set up and the financial is making it a bit broken. So no matter where you are, if you're at the tiniest rural EMS versus the largest EMS, you're all facing issues. There's no denying that at all. What this is meant to show is that there's a little bit of nuance and can help us in terms of, like, all right, if we're going to bump up and seriously invest in EMS, let's invest in these few things, in these things, and make sure we at least are covering our bases in terms of providing the best services possible. So this chart looks at, this dark red is agency that has a trained manager, and then this kind of lighter orange is agencies that do not have a trained manager. And so we asked the question, does your agency have a recruitment plan? This is Minnesota Department of Health asking, does your agency have a recruitment plan? 71% of agencies that had a trained manager were more likely, 71% said, yeah, we have a recruitment plan, versus 45% for agencies that don't have that manager. Recruitment is always difficult. Again, half of the agencies, again, not great, but better, half of the agencies said it was difficult to find, that recruitment was difficult, versus 75%. And then 70% of the agencies that had a professionally trained manager were more likely to have a retainment plan, versus only 28% for agencies that didn't have that manager. And again, that's not a knock on the managers themselves, but rather, do they have the skill set and the time and the resources to actually do these things? Growing pool via collaborations, consolidations was another thing that came up in our businesses. So this is kind of like an example of what that looks like. Instead of having, an ambulance for a small group of people, is there a way to kind of consolidate our resources to a larger pool of people? Again, just economies of scale. When we did our data analysis, what we noticed was that agencies that were collaborating, or particularly a part of a larger healthcare network, were more likely to offer advanced life support, more likely to pay their staff, they're more likely to afford more staff, and they had access to better equipment. And so those were some of the big things that we noticed. And as Dylan explained, we have a pretty good framework in Minnesota. So we have 8 EMSRB program regions, and we have more than 250 ambulance service areas. We already have a framework. And what's really interesting is that Minnesota is actually looked at by a lot of other states as being kind of the measurement stick in terms of where or how organized the state should be regarding their EMS, their system. What's kind of fascinating is, it used to be that states were a hodgepodge of EMS agencies, and like you would have a crash and all of a sudden there would be this race of 2 different ambulance agencies to the scene to get there first so they could, provide the service and then get the revenue. We don't have that in Minnesota. We have a franchise system where we got 1 license per area. That ambulance agency takes care of that area, and no other ambulance agency can come into that area to provide the service unless given permission to. And that really just provides the sustainability in the foundation that these agencies know, all right, this is my region. There's no one else competing with me. I just need to do this really well. And what that does is maybe that means we can then do a lot more in terms of kind of consolidation or coordination among multiple areas. Interview statements that we saw, it's becoming clear that we have too many small EMS agencies to sustain them all as individual operations. Finding ways to collaborate and consolidate is the biggest tool we have to utilize economies of scale. Agencies of varying size can share trainings, rigs, budgets, and even staffing is kind of what we're talking about. So what's stopping this strategy? And what was interesting is, one, there's just a history and the intertwined nature of EMS in community. There's just, it kind of goes back to what I call like when all the high schools or the school districts started consolidating. There's just a lot of passion. There's a lot of identity. There's just like losing your ambulance agency, or that threat of losing your ambulance agency feels like some sort of failure or some sort of loss or another nail in the coffin for small towns. That's kind of the mentality and the narrative behind it. And that was one of the bigger things that we heard when talking to people, is this like, yeah, we actually approached our neighbors and they just didn't want to, they didn't even want to discuss it or talk about it, because there's always that threat, just like in schools. Sure, we'll consolidate, but who's going to get to school? Where's the school going to go? Who's going where? And that just gets to be kind of a tough and difficult conversation that nobody wants to map out. The last thing I'll say is a nuanced approach for transforming EMS. And again, in interviews, like a lot of folks are actually really confident that we have a system set up, a framework at least, that does work for us and can work even better for us. It's just trying to find that nuanced way of moving forward. And I think a lot of folks, when looking at rural EMS, they probably think in their heads, oh, the smallest EMS agencies are the ones having the largest trouble with staff recruiting or whatever. But that actually wasn't the case when we did the analysis. This is just one example. So percent of agencies that find it difficult to recruit staff by size of population served, right? You would have expected this to be kind of a ladder down. But interestingly, and again, keep in mind, 70% of agencies, not a great number. But what this does show us is that, you know, these folks that maybe have larger call volumes, so the population between 25 and 5,000 probably have a larger call volume than the less than 2,500, find it even more difficult to recruit staff because they're on a lot more calls and they still don't have enough money to get paid. They're still volunteers, right? That's the kind of nuance in EMS that gets a little bit tough and a little bit sticky. Again, here's another example. Percent of agencies' response to barriers to staff recruitment by size of population served. And this is, you know, the lighter blue is the less than 2,500 all the way up to the 15,000 or greater with the darker blue. And one of the barriers, inadequate pay. These two in the middle were significantly higher as being a barrier to staff recruitment than our smallest agencies being served, right? Only about 26%, where nearly half said inadequate pay was a problem. Again, kind of going back to this idea that higher call volume, but not enough to actually pay your staff. So we're asking a lot of our volunteers and they're not getting paid. Where in terms of a smaller agency, maybe volunteers is all they need. Maybe that's perfect and they can make that work really, really great for them. Time availability was another one where just, again, you get into that kind of moderate level, 2,500 to 10,000 population served, and it's quite a bit higher. I did another one, apparently. Percent of agencies that the amount of time to train is a barrier to staff. And here's where you would see, you kind of see the ladder, right? Less than 2,500, almost 80% said. And it kind of gets again to that, yeah, we have calls, but we don't have that many calls. Do we have to be trained that much, right? And they probably do. Don't get me wrong. This is more just to highlight some of that nuance moving forward on this stuff. So what does this have to do with policy? We need to be thoughtful. We need to be nuanced. And I always like this quote: if you've seen one rural EMS agency, you've seen one rural EMS agency. So recommendations that we put forward, the primary service area framework established by Minnesota was appropriate for its time. It provides a necessary foundation for rural EMS to take the next step. But it's time to kind of consider what types of incentives can we put in place for neighboring EMS agencies to start discussing collaboration and consolidations. And we would even suggest that this means providing technical support and facilitation to help neighboring communities have those conversations and provide the data, because it could be that if you have service areas that are going to work together, where the ambulance station might be parked might change. And we can do that statistically to try and figure out where is actually the best place to have this. We didn't do that with our schools when we were having that conversation. There was no statistics. There was no kind of debate on actually this is the best place to have a school in terms of traffic patterns and where the kids are coming from. It was just a bloody battle. Maybe we could do that better here. Provide resources that help ensure all agencies are professionally managed. And again, this could be a regional approach to it. So maybe we don't need 270 professionally trained managers, but maybe we need 75 and they kind of manage a group of agencies. Conduct research on the threshold of call volumes versus full-time staff. That's kind of getting back at that, as call volumes go up, they're not getting enough revenue to pay their volunteers, but yet they're burning out their volunteers because the call volume is going up. Is there a threshold there? We need to do some research on that. And creating eligibility requirements for providing support to an agency. Use multiple variables to measure severity of challenges. Try to avoid overly simplistic measures based on one volume, like just call volume. There's a lot of things that go into this. And then there's a lot of conversation around putting in some kind of a one-size-fits-all performance standards that all agencies need to meet. And again, just the Center for Rural Policy Development, we're kind of a broken record. One-size-fits-all typically doesn't work well when we try and start to consolidate rural and metropolitan type agencies. So with that, we're going to dive into the panel and we'll be answering questions. And I know Kate Redetz from Park Street Public is going to be facilitating discussion, and I'll be a part of the panel as well and help answer questions. So Kate, go ahead.
Thanks, Kelly. And thanks for everyone who is tuning in today. I'm really excited to be part of this discussion, focusing on understanding the challenges for both rural and urban EMS systems. I'm Kate Raditz, as Kelly mentioned. I'm the Senior Principal of Public Relations and Communications for Park Street Public. I'll be moderating today. And prior to my role here, I had a long career in journalism, most of my career at WCCO Television as a reporter, and also worked in newspapers and other TV stations and radio as well. So I'm always happy to be able to ask a question, and especially on a topic as important as this one. I'm going to introduce our panel quickly, and then we'll jump right into the discussion. A couple of them you've already heard from. So first we have Ann Jensen, the Executive Director of Southwest Minnesota EMS, Kelly Ash, Center for Rural Policy and Development, Mark Jones, who's the Executive Director of Minnesota Rural Health Association, and Dylan Ferguson, who you also heard from, the Executive Director of Emergency Medical Services Regulatory Board. And thanks to all of you for being part of this discussion today. So I have a list of questions, and I'm also going to be keeping an eye on the chat. If you do want to enter into the chat or the Q&A, I'll also pause every now and then to see if there are questions. So I'm going to open it up to the group for each of you, starting off with, what do you feel are the biggest challenges facing EMS today? You may have a different perspective depending urban or rural, but what do you feel are the biggest challenges? And we can start with Ann.
For me, it's staffing. That's what we see the most out here. We used to think it was pay, a lot of it, but even as we see call pay increasing and wages increasing, we're still having a hard time getting people to the table. At Southwest EMS, we even reimburse people for their education. So like for our first responders and our EMTs, it's basically free. We do help medics as well, and we still can't find the people to fill the seats. So it's a workforce thing.
Thanks, Anne. And Kelly, what was there anything in the report? I know you just went over it, but the biggest challenge?
Well, I think just to follow up on what Ann is talking about. So and I was going to say the same thing, but let me just provide the context in which rural EMS is trying to work in. And metropolitan areas, I think, are feeling this pressure too, is just workforce shortages in general, right? Like we hit for 20 years, we've been talking about this cliff occurring, that the baby boomer generation kind of retiring out. Minnesota is a slow growth state. We don't have enough people to fill in the people leaving. And so what this ends up doing is just creating a huge gap in the number of opportunities available in our rural areas versus the number of people that we have in our rural areas. And so, yeah, moving forward, we have an aging population that are going to have to rely on EMS even more over the next 5 to 10 years. And we don't have anybody to take care of them. And so that's EMS agency in a nutshell moving forward, in my opinion.
Mark, would you also say it's staffing, or did you have another perspective too?
No, I'd agree. I'd agree 100% that workforce right now, whether it's metro or rural Minnesota, it's the workforce. It's the lack of people. The pool is just so small to pick from, and then I'd say that there's funding issues that go with that, and that can be sort of a chicken and the egg type situation where there's a lack of funding. There's difficulty with hiring and retaining workforce, but then that can go back to the issues with funding.
And Dylan.
So 4 out of 4, unanimous agreement of workforce. Really, I think Mark hit on a good point that we're really facing workforce challenges both in greater Minnesota, but also in the metropolitan regions. And to me, when I look at it, it's a question of it's a question of culture, and not question of EMS culture, but societal culture. Because really, good, bad, or indifferent, society has changed. We've got more two-income households at any time in human history. More people have to travel for work, and you can't you can't live in the same community and you work. And we see a lot of that in greater Minnesota, of travel for work, travel for kids activities and things of that nature. And you really couple that with the fact of the tightest labor market that we've ever seen across this country and across the state. And I think the last unemployment rate that I saw was, the lowest it's ever been, of below 2%. And then you tack on and this was from another Center for Rural Policy report that says, without growth in domestic or international migration, that we're going to see population continue to fall in greater Minnesota over the course of the next 20 to 30 years, right? So when we put all these factors together, Kelly said a cliff. I call it a perfect storm. And really, all of these confluences coming together could not be coming at a worse time, really, as we try to dig ourselves out from a pandemic, which certainly had an effect on the workforce as well.
Thank you. And I saw a question pop up in response to that I think is interesting. Someone was asking, what is it that people want? What can communities do to help recruit when we know that the workforce is such a huge issue across all areas? And actually, we can go in reverse. Dylan, maybe I'll start back off with you this time.
Sure. So, that's a really tough question. And I think it actually comes back to kind of what Mark said with funding. And I don't think that all the funding has to go to the individual people, but ultimately you have to have the infrastructure, and you have to have the ability to be able to compete with those other entities that you're really competing with, for whether it be employees or volunteers. So when we take a look at the healthcare sector overall, and we look at salary data, we can see that a registered nurse in Minnesota, in most areas of the state, makes double that of an EMT or a paramedic. And so we hear anecdotally of a lot of individuals transitioning to other jobs within the healthcare sector. In fact, you'll hear me mention it a couple of different times today, but we just finished a survey of asking people who let their EMT certifications expire, why'd you leave? And are you still working in healthcare? And what we found was that about a quarter of people who left EMS are still working in healthcare. So really, we're competing against other sectors within the healthcare community. We're competing with general industry. And sadly enough, those are areas that, they have a much higher wealth of financial resources by which to compete for that limited labor pool. And I really think, we have to try to solve the problem of demographics, which are not on our side, particularly in greater Minnesota. But we also have to look at that funding piece. So I think it's kind of two-pronged. And that's what I would say. That's how we make the pool bigger. Also focusing on trying to, maybe involve high school students, get into the schools and try to recruit people to the workforce maybe earlier on than we had been targeting in the past. But the one thing that I think all of the panelists would agree on is that to that question and to many of these questions, there is no one silver bullet. It's going to have to be a mixture of a lot of different policies.
There we go. Thanks, Dylan. Mark, did you have anything to add on that? I thought that was interesting. He talked about, recruiting, younger in the schools. Is that something that should be looked at, trying to make sure that they are reaching out to younger people to say, hey, we want you to go into this field, or what do you think makes the most sense?
Absolutely. I think building that pipeline from our K-12 through higher ed into the workforce, that's going to be really critical. And if we look at over 86,000 open jobs right now in rural Minnesota, that's a very competitive market. And it's not just healthcare that's going after these kids. Our rural high schools we have smaller class sizes than we did in the 70s when we really saw EMS break out. We've got more opportunities. We'll say that kids don't want to stay in their small town. And if they do want to stay in their small town, they've got just a broad range of opportunity. So to get to these young kids, to interest them in EMS and healthcare careers, and I think it's okay that these kids move on in through the healthcare world. It's okay. But to build that pipeline is going to be really critical.
Thanks, Mark. Kelly.
Well, I think the bigger systematic, we need to change the way in which we're thinking about, in my opinion, economic development in general, particularly in rural areas. I can't tell you how many times I still see applications for grants where somebody start an initiative, and on the grant application is how many jobs will this initiative take, right? Like, I think anybody filling this out wants to throw themselves out the window the next time we have to answer that question. We don't need more jobs. We're creating initiatives to create people, to create workforce, right? And I think there's short-term and long-term pieces to that. But again, it's very systematic. And so if we look at short-term and we look at the labor force, we kind of try and find, okay, what are the pot of pools that exist? This is kind of what companies are doing right now. We know in Minnesota that there's a significant amount of people that dropped out of the labor force over the past few years that are 55 and older. All right, for an EMS agency, what recruiting them into their workforce and their pool, what incentives might that look like? We also know females in rural areas dropped out of the workforce at a pretty high rate. Okay, what kind of incentives then do they need to maybe entice them to either volunteer some of their time? What does that look like? Is it providing subsidies for childcare or providing childcare itself, right, in the agency? I don't know, but I think this idea that we need to get economic development to focus on people recruitment and not job recruitment is a whole restructuring of the way in which we move forward. And again, it kind of points towards that pipeline that Dylan and Mark were discussing. One example I always say is the Build Dakota program in South Dakota. It was the Sanford Foundation and the state of South Dakota put in a big pool of money to fund 300 students to graduate out of South Dakota two-year college in an occupation considered a need. And if they live in South Dakota and work in that occupation, they get their tuition and books paid. They were going to do that for 4 or 5 years. And it's been 5 years, and they're continuing to do it because they've had so many employers say, hey, I will sponsor this kid. We'll pay for his tuition books, no problem. If he wants to live here and work in my company, great. Community foundations have been doing it. Community foundations have said, we need electricians in our area. We got these 2 high school kids that'd be great at it. They want to do it. We'll fund them. Why we're not doing things like that in Minnesota just boggles my mind. And again, these programs like Build Dakota isn't income contingent. It doesn't matter how much that kid's family has made, because in rural areas, it really doesn't matter that much. It's just we need people, not necessarily certain types of people or to help certain types of people. It's just to get them in the workforce and in the pipeline. So I think those types of ideas are pretty important moving forward, not only in EMS, but just in rural economic development in general.
And I think I heard you say right off the top that you've already done some tuition reimbursement. Have you found that to be effective in recruiting?
Yeah, you know what? It is working. I think what we see is we have classes out here too that have started in the schools and not as great, and they are doing exactly that. They're hopping into other careers, nursing, or actually I work on a small ambulance crew here, and we've had 3 of ours are now medical doctors. So yeah, I think to help pay for it is great. I think we need to really encourage this too, that this is, you can make EMS a career as well. You can, just like nursing, you go to a nursing assistant and then you're a nurse. We can be an EMT and go on to be a paramedic. So I think paying for it will help. I think getting it out there at a younger age is crucial.
Thank you. And maybe if just one of you can jump in on this, if you know the answer to this. Someone is asking, how many healthcare facilities, if you know, how many healthcare facilities will hire people under the age of 18, or can they?
So I can speak from an emergency medical services perspective. I can't give you an exact number. However, in Minnesota, we do not have a minimum age for emergency medical technicians or for emergency medical responders. I do know that there are some services that are operating with EMTs that are actually high school aged, and their school will actually allow them to leave during the school day if if a call comes in and they're needed to help staff that ambulance. So from other healthcare professions, there may be a little bit more of a reluctance to do that. But from an EMS perspective, there is nothing from a legal or a regulatory perspective. Usually where we run into barriers to that actually has to do with the insurance companies. Typically with auto insurers, they won't allow someone to drive a $300,000 emergency vehicle with lights and sirens if they're below the age of 18. But that is very much service specific. But absolutely, there are 16 and 17-year-olds that are operating through the state.
Thanks, Dylan. My next question actually comes back to what Dylan was talking about at the beginning, looking at how EMS systems are run. This question, I'll present it to all of you, but do you find that the general public, the average citizen who doesn't work in an EMS system or doesn't work in the medical field, do they understand, or do they tend to not understand how ambulances are run? And do you think that impacts the type of support that's needed to address these challenges? Kelly, I'll start with you.
That's a great question. And one I'm not prepared to answer right now. I'll pass and see what the folks say about that.
Yeah, that's fine. Mark, are you able to weigh in on that?
So I think historically, the ambulance service was something that was just expected to be there and probably didn't have the attention that it has today because that wasn't needed. The ambulance service was there. The people were there. It happened. It was one of those services in your community that happened. However, our communities are becoming more aware. It's all over the news. We see it every day. It's in local and regional, national newspapers, news outlets. But I do think that, and as we continue to see ambulance services being led by managers who have the time to reach out there to their communities, our communities are becoming more aware of the challenges. They're becoming more aware of what the ambulance service does and who their ambulance service is, and maybe also, and this can also go to the metro, who the provider is, what the response times may be, what the level of service may be, and then ultimately how the healthcare system operates with the ambulance service within it. So I think we're becoming more aware of the EMS system in Minnesota every day.
And do you have anything to add to that?
No, no, I think Mark covered it very well. I do, I've been in EMS 26 years and I really do feel like our communities are more aware, just like he said, the systems are more aware, and that we aren't just a vehicle anymore, that we do care for people, and there's more support out there.
Great. Dylan, anything else you wanted to add?
Yeah, and I don't mean to take a contrarian view here. However, I think that the awareness is better, and I think the awareness is better a lot because of events like this. I think it's important that EMS services, be transparent with their communities. All too often in public safety, there's this mentality that we can never show that something is wrong, right? And if we don't engage our communities and they don't know, then that's a struggle. So I do think that the awareness is increasing. I still don't think we're near where we should be. And there are, I think, a lot of individuals who are still confused that of how all of this gets paid for. There are some people that I speak to. They think, well, my taxes pay for this. Well, no, not where you live. That is not the case. So I think that EMS has to do a better job of tailoring its message. It has to do a better job of engaging, those community members, because fundamentally the challenge that we face is that we're a service that people don't like to think about. People don't like to think about the fact that they're ever going to need an ambulance. And there are people that I talk to, general members of the public that say, well, I'm healthy, I'll never need an ambulance, why should I care, right? And the problem is that if you don't have the public interest in these types of services, then it's unlikely to get the legislative attention that it deserves. I think right now we're at a unique crossroads, and it's important to strike while the iron is hot, so to speak.
Now I would like to kind of jump on board with Dylan too, a little contrarian as well. I feel like we hear a lot about fire departments. Like they put on a fundraiser, the place is packed. Everybody's like, yeah, firemen, heroes, and that's great. They are, don't get me wrong. But EMS agencies answer 3 to 4 times more call volume than our fire departments do. And fire departments are funded to be 24-hour ready for the most part. It's kind of crazy to me, our expectations on if my house is on fire, yeah, the fire department's going to show up. We have the same expectations for the ambulance, but we don't have a similar kind of feeling towards it. And I do believe that is starting to change, absolutely. But I also think the confusion around EMS, when I talk to particularly rural people, they're like, oh, the hospitals get paid for that, or oh, the hospital owns it, or whatever. And it's kind of crazy to me. They don't actually understand, no, these are volunteers. These are people trained, the biggest subsidies for our EMS agencies are the people with the pager, right? So anyway, I just wanted to throw that out there that I still think we got some work to do.
Thank you. Going back to the first question, you all said that staffing, the workforce shortage is probably the most major challenge facing EMS systems today. What immediate impact is that having, on employees, on the services? Are we seeing some of the impacts already from that workforce shortage, and what is it? Mark, maybe we can start with you.
Well, I think we're seeing people leave the workforce, and Dylan spoke to it, and I'm sure he'd be happy to speak more to it with the work that they've done. I really don't know the answer to that one. I think I'm going to leave that one to Dylan.
Sure. Dylan, did you have any thoughts on that?
Oh, Dylan has thoughts on plenty. The panel will tell you I'm never short of opinions. But I always also try to bring information to make those opinions informed and share information. So I think that the workforce situation is really expanding the rate of burnout and mental health issues that our emergency medical services providers face across the entire state of Minnesota. So once again, we went to the source and we wanted to ask those people who left, why did you leave? And what we found is that 43% of the paramedics who let their certifications expire, who replied to our survey, reported mental health and burnout as being an influential or a very influential factor to their decision. So that particular issue is more prevalent in the metropolitan area than it is in greater Minnesota, at least according to the numbers. A lot of it appears to, really be related to COVID. That really took a toll on medical providers of all types. But what really happens is that individual providers, EMTs, paramedics, wherever you are, it doesn't matter, are expected to do more with less. There isn't more support. There isn't more support in the immediate future in the pipeline. We had kind of hoped that we would be able to get something through and passed by the end of the last legislative session, but unfortunately that didn't come to fruition. But really, it creates a vicious cycle. When recruitment is down and we can't bring those people in, call volume continues to increase 5 to 7% every single year. So there's more of a demand for service, and also a different demand for service. I think I saw within some of the Q&As coming in about long distance interfacility transfers, particularly mental health transfers, that really are very resource intensive. And services across the state are doing their best to stay focused on, meeting their 911 responsibilities. But Kelly kind of hit on it in his presentation that with the kind of hub and spoke model creation in the healthcare system overall, that places an additional burden on EMS. So then we go back to that cycle, calls are up, and by calls increasing, less people coming in, more people leave, and then those that are left behind still have to continue to do more with less. And it's really a self-fulfilling prophecy, if you will. So burnout and mental health concerns for our providers are certainly one factor. And then the other factor is it's certainly timeliness of care. To be honest, response times are not the best measure of clinical performance. However, it is something that is important to community members. It's an aspect that people expect when they dial 911, either a fire truck or a police car or an ambulance is going to show up at their door. So while there may not be a lot of evidence from it from a medical perspective, there certainly is from a service perspective. I think that to an extent we can, if left unreversed, we could see service areas kind of get larger, and we could see, longer delays. And so it goes back to setting realistic expectations against the fiscal realities, right? And the analogy that I usually like to use is I think everybody would love a Cadillac. Everybody would love to drive the Cadillac. But when we take a look at what we're willing to pay for, maybe all we're willing to pay for is the 1964 Yugo, right? And that is, those types of disconnects can really be demoralizing, so to speak. So I think there need to be clear community expectations, but also that those expectations have to be adequately supported.
I was going to say something too regarding the workforce shortages. So you got the taxing on the actual agencies and the volunteers there, but we have to look at it from the employer perspective, particularly in rural areas. Most of these people are employed somewhere, right? Those employers are suffering from workforce shortages, and yet we're asking our employers to let some of their staff off. In the case of this Chris Bourbon here in the Q&A, 4 to 5 hours on a hospital transfer, even up to 15, 16-hour round trip for mental health. Like, they're clocking out of their job to do that. So not only is the person volunteering subsidizing EMS, but now so is the employer themselves by letting those people off of work. And there is some kind of anecdotal evidence gathering that employers are getting a little more like restrictive in terms of their employees' ability to volunteer for such things.
Thank you. I'm going to go to I see there's a couple of questions from people tuning in. First, and I'll just open this up to the group if someone knows. First question is, do ambulance district boundaries need to be changed? Does anyone have thoughts on that? Dylan, I see.
I'll go ahead and start with this. I think that Kelly's I think that was kind of part of Kelly's research and may have been what he was kind of alluding to, of trying to take a look at some of those boundaries, or what is legally referred to as a primary service area. And I also will highlight that keeping that concept, but maybe taking a reevaluation of those was a recommendation from the Minnesota Office of the Legislative Auditor. So I do think that that is an issue that is certainly being discussed at the highest level of government right now. But it's also important that we have to make sure that, if we do go down that path, I liked Kelly's approach of using call volume data and using other factors, because ultimately, if those areas are not economically sustainable, then we have continued to, we continue to face the same challenges. That being said, this is where the different opportunities for collaboration occur. I've seen several examples, and even in my short-term tenure here in Minnesota, of multiple municipalities coming together and implementing that concept of, you have kind of one operator, and you kind of achieve those economies of scale. We've also seen other examples of healthcare systems not taking over, but helping support other services, whether that's with staff sharing agreements, with management agreements, and things of that nature. So there are a lot of existing tools, but as it stands right now, there has to be a willingness by all sides to be willing to utilize those tools. And certainly, from a regulator perspective, we do not take a position on consolidation. That is really outside our purview. However, we are here to provide data, to provide information, and to provide technical assistance to those individuals that want to engage in those conversations. But going back to the original question, it's something is certainly being examined. And there are probably certain areas of the state which are actually perfectly happy with how theirs are currently operated. And that's going to be the key in finding that balance of respecting that local autonomy and not upsetting what is currently working, but also working to address the other areas of the system that aren't working as well as they should.
And Mark, I saw you popped on. Yep. Did you have anything else to
I was
add?
gonna, Dylan beat me to it, but it's a great opportunity when we talk about the boundaries. It's a great opportunity for the collaboration, just the conversations amongst managers when population shifts happen, and the need for possibly having a substation and who best to serve that population area, and to be able to make those changes in the boundaries that make sense, that are agreeable, and that the community is in support of. This is one great area where we can get our communities involved and our policymakers at a local level involved. When we talk about the service area, the population that's served, and maybe what's the best method to serve these folks. And then I saw in the comments there was a comment about dynamic adjustment. When one crew was out in a primary service area, and that the neighbors then cover that. So that collaboration and cooperation, that could be a great opportunity for a dynamic deployment system where everybody is coordinated, or a group of services are coordinating together to make sure they're covering each other's areas, and they're there for their neighbor when they truly need them. So there's great opportunity for this.
Thanks, Mark. I want to move on to talking a little bit about call volume and funding. In this report that Kelly went over at the top, it really looked at call volume as the biggest influence on how much revenue an agency can access. Can you talk about how it funding changes for rural services and urban services, how it's impacted? Let me start this over. Does funding based off of call volume work for rural services in the same way that it would for a metro, or how do those differ? Maybe Anne, if we could start with you.
Sure. Well, in the rural area, obviously our call volume is much less, so therefore our revenue is much less. So, I mean, that's the biggest difference. But then, you know, to cover the urban area, you have to have more trucks, more people. So it eats at your revenue that way too. So no, I don't know. I don't know that that's the best funding stream. No, Mark has probably done a little more research on this, or Kelly, to be able to answer that a little better, but call volume is very difficult for rural areas. And especially when you have a lot of little services that bump up to each other, such as we do out in Southwest.
Mark, did you want to add anything?
Yeah, I would. So call volume, it equates the same whether you're rural or you're metro, whether you're doing 100 calls a year or 10,000 calls a year. You know, we're paid on a fee for service system, so we're only paid when we transport a patient. However, if you're in an urban area where your transport times are 4 or 5 minutes, and you have the volume, so you're doing 1 or 2 calls an hour per unit. Your utilization is there. You're meeting that economy, so you're generating more revenue per hour by each ambulance. Where when you go into the rural area, you still have the same overhead cost per unit, but you're maybe doing a call a day. And those calls tend to take longer. So you're looking at an hour and a half to in the questions 14 or 15 hours for a mental health transport. So that's where the disconnect comes, is when we have an ambulance service that's doing X number of calls and generating the same revenue per call as anyone else across the state. It's that time that there's no calls and no revenue being generated, but there's still expense. And that's why we see this model of volunteer or partially compensated staff. And the question we have to answer is, who is going to fill that gap of the difference between service generated revenue and the cost of doing business? So whether that's the local taxpayer, and there was a question on it, and we have the ability to set levies at the city level, assess levies. We have the ability to develop taxing districts, which could then raise revenue. So that's the big question, is when it costs more to have the service than you can generate in revenue, where is that difference made up from? Right now, that difference is generally made up by the staff, the people that work for that service, subsidizing the service, i.e. working for nothing or working for small stipends.
Great, thank you. I saw a question come in, and I'll open this up to the group again. Someone is asking, is there a minimum level of service expectation, and who sets that expectation? If anyone has anything to weigh in on that. Yeah.
So in terms of the minimum level of service expectation, yes, there is a minimum. I want to say something in the neighborhood of 98% of the square mileage of Minnesota is covered by what we refer to as a primary service area. So that goes back to those boundaries. And as part of those boundaries, each organization that holds a license is expected to be able to provide service 24/7, 365 days a year, with at minimum a basic life support ambulance. So that's that is essentially the legal standard, which is set forth by the state. And so Kelly, at the very beginning in his presentation, he used the term essential service. And essentially, EMS is an essential service in the state of Minnesota. However, that onus is not placed upon a level of government. Rather, that primary onus is actually set upon the ambulance service provider themselves. So that's the minimum level of expectation. There are no legal standards as to saying how quickly that service must be provided. And that was done partially, I think, intentionally, because it goes back to what the Center for Rural Policy was concerned with about top-down one-size-fits-all mandates. Because from a minimum expectation point of view, it would not necessarily be reasonable to expect a response time of an ambulance, say, compared to the city of St. Paul, for someone in rural Dawson to expect as timely of a response. So there is an obligation for one basic life support ambulance to be able to respond 24 hours a day in each of those primary service areas. And that would essentially be the minimum level of expectation. There are some services that hold advanced life support licenses, or those paramedics, those more advanced care. And if they hold one of those licenses, then the expectation for that community is one advanced life support available 24 hours a day, 7 days a week. So that would be the legal minimum. And that is set forth by state law. But the law does not get overly prescriptive in how that is carried out, because Minnesota is so diverse, both culturally and geographically.
Great, thank you. Going back to the discussion about the workforce shortage and even the challenges beyond that, the report talks about pooling resources. Would pooling resources help? Or is this already being done in the metro area or in rural Minnesota? And have we seen that work? And maybe if we can start with you.
Sure. I think it is something that it is being done here. I have a little county that actually does it for some of their mental health transports. They have a vehicle that they take the people that don't need an ambulance, that need to go to a mental health center. And so they have pooled all the people within the county. They have requirements that you have to have a CPR, you have to be CPR and at least first aid certified. And they have a text group that they send out a text when a transfer is needed. So I think they have like 46 people in the county in that pool that they can call from, to take these transports. So when you think of like an ambulance service that has 12 to 15 people, it's 3 times your pool. When I look at a lot of my little services that I have out here, and my towns are close together, so they live in one town and work in the other. Do I think that they could be on that ambulance in the town that they work in and be on the ambulance in the town they live in? Absolutely. It would just be that they'd have to know the policies of both ambulance services and what their medical directors, maybe they'd share the same medical director on both services. But yeah, I think that collaboration is really there, that we could use people between those services. Like I said, this little county that does it has proven to work. It works well for them, especially with the labor pool as short as it is. We have to pool our services and kind of start thinking outside the box on how we can make that work. So collaboration, I think, would work.
Thank you. Kelly, did you want to weigh in based on what you saw in the report?
Yeah, how about I provide you an example of what I found kind of interesting as I interviewed the CentraCare folks, and CentraCare itself owns, I forget how many ambulances in the state of Minnesota. I want to say maybe 8, something like that. And the agencies themselves range from a couple hundred call volume a year, all the way up to over 1,000 call volumes. It's a very diverse number of agencies that they operate. And they gave a couple of examples of just being able to, one, have centralized management. So they have a couple people that they manage all of those agencies themselves and work really hard at it, and they're able to write the grants. When they go out and buy ambulances, they're able to make agreements where they can buy a couple ambulances and get them at a reduced rate, right? Even equipment. They can purchase equipment or supplies in bulk and get it at a reduced rate. It's all about economies of scale. But also what was kind of interesting is when they had, so we talk about, consolidation of EMS, but even this kind of idea of pooling resources and relationships with healthcare services at CentraCare. I know in Swift County or the Benson area, they're able to do some part-time, community paramedicine, right? So they actually have somebody there. I'm sorry, they have a community paramedic there that will come in and do some door calls, but that person will also work as being able to provide advanced life support for the Benson area. If they're in that area already answering a call, they'll just let the agency know, hey, I'm here, I'm around. If something big comes up, let me know. I can jump on the truck with you. And provide that support. So again, like being able to have those connections and at least being able to provide a little bit higher level of a service once in a while, that's super beneficial. And it's kind of a way in which you see some of that consolidation helping. So.
Thank you. Mark or Dylan, was there anything else you wanted to add?
I think he summed it up beautifully.
I would
Great.
agree.
Great. There's a question in the Q&A, if any one of you wants to answer this. What about the state providing funding for rural ambulance services, or possibly a statewide fund for reimbursed uncompensated ambulance response that any licensed ambulance service could access? Does anyone want to give a shot at that?
So I don't necessarily, I'm trying to think, and I think I heard a bit of a discussion of that during the last legislative session. Certainly, uncompensated care pools are not they are not completely unheard of at a state level. Typically, emergency medical services are often not made a part of those, and part of that goes back to, I think part of that goes back fundamentally to an issue we started with at the very, very beginning about EMS being looked at overall from a federal level and from a top-down level of transportation versus being a healthcare provider. And I think part of the reason why that continues to perpetuate is whether you look at Medicare, whether you look at Medicaid, whether you look at uncompensated care pools, right? There's only so much money that's there. The pie is only so large. So if you put additional providers into that pie, then you have those other provider types, which, in order to give something to someone, you have to take away from somewhere else, or you have to increase the underlying appropriation. And I think that right now, those are kinds of the discussions that are being had. So when we go back, it's like it may have made sense for EMS in its infancy to start as a supplier that may have reflected the best wisdom of its time because of how it was developed. And there was such a gap in the clinical care. But over the course of the last 20 years, EMS has advanced so much. And that way of thinking is simply antiquated, and is really an archaic way of looking at it. So I think that trying to make that transition and avail ourselves of proposals just like that, of those uncompensated care pools. But it looks like Mark piped up. So Mark, I'll kick it over to you.
Yeah, absolutely. So we have had an uncompensated care pool in Minnesota in the past, prior to Medicaid expansion. When we had high deductibles, we had a great number of folks that were uninsured, and this, of course, is before they became eligible for Medicaid. So we had this pool, and I think it's worth the conversation, and it's worth looking into policy. I know it's been pursued in the past, but when we look at ambulance services are required to provide the service. So if they're called, we can't say no. It doesn't matter. We don't do a credit check on you. They don't look at whether you paid your bill the last time to the ambulance service. We go, we provide the service, and then we're reimbursed for our service depending on who the payer is, and what the agreement with that payer. Well, in rural Minnesota, we have a higher number of high deductible plans. Those people who have commercial insurance or who have employer-based insurance, we have a higher percentage of people in rural Minnesota on high deductible plans. So that is an issue when we provide the service and we don't care who the insurance is. But however, I think it's something we could look at and should look back at, is having that pool for our ambulance services and our emergency rooms where we can't deny service based on payment. But to counter those high deductible plans, those non-payments of the bills that are out there, I think would be a great idea.
I'd like to get one more question in for all of you before I'm going to turn it over to Julie to wrap things up so I get everyone out on time at the top of the hour. I think my last question is, what is your concern of what could happen with EMS, with ambulance services if these issues were not addressed? I mean, what scenarios are we talking about, or what is your greatest concern of what could happen for the future of ambulance services if these things are not addressed, these challenges that you've talked about today? Dylan, maybe if you want to start, and we'll just go down.
Sure. So I think the first answer to that question is that the path that we're on is currently not sustainable. If policy changes related to reimbursement or how emergency medical services is funded, the EMS system of the future will not look as the EMS system of today. Of that, I can say without a shadow of a doubt. In terms of immediate effects, the one thing that I will say about EMS is they are very good at adapting and doing the best they can with what we have to work with. But the problem is that there are only so many Band-Aids that can be applied to a situation and to try to keep a system together before ultimately it has to change significantly. And some of those changes, and I kind of touched on them a little bit earlier. It could be the timeliness of care in the intermediate to long term. It could be what levels of service are going to be available. Maybe areas that had paramedic level service available today, may not be able to maintain that in the system of the future if these issues are left unresolved. But ultimately, and it opens the system up to any number of other disruptors. We have seen, whether it be Uber or Lyft or different types of other transportation companies, of really, disrupting those types of situations. And certainly in some instances, it can be considered innovative and disruption is good. But I am not so confident that, disruption of a key public safety that people rely on, in moments of, severe injury and disability, I don't think anyone is comfortable with that level of unpredictability. So it's that unpredictability, that disruption, and such a large transformation of the system that no one truly knows where it would go. Those would be my primary concerns, Kate.
Anyone else want to weigh in before we wrap up? Anne, Kelly, or Mark? Go ahead.
I would just ditto absolutely what Dylan said. There's going to be this just isn't sustainable how we go now. I mean, we need workforce. There will be longer response times if we can't beef up our workforce. There probably will be a change in licensure of who does respond. And he's right, EMS adapts. There are amazing people out there, but it's how far we can stretch those that are still in the workforce with us.
Yeah, and I'll just say, I agree that I think in the end, like into the future, we will figure this out because it's such an essential service. What my hope though, is that it's not going to take stories of the ambulance not showing up and people not getting a service. I believe we know what the answers are. We have lists of solutions and ideas on the table here. We know what to do. We have a framework that's set up to do it well. Is there the political will just to get this done, or do people need to die first? Right? Like, is that just the reality to wake people up? And I hope that's not the case, but that is my big worry.
And Mark?
No, you got it there, Kelly. That's my biggest concern, is that we get to the point where we don't have the service showing up. And I sure hope that we as an industry, we as healthcare, and we as a state of Minnesota, we put forward those resources that these folks need, especially those who are at their end. They don't know what to do, that we step up and we help them out, and we make support available, and we make sure that it's easily accessible.
Thank you so much. And I'm going to turn it over to Julie to wrap things up.
Great. Thanks so much, Kate. First, I just want to say thank you to everyone involved in EMS. What you do is fantastic work, and thank you from the bottom of our hearts. I know that my family personally has been affected by EMS and lives have been saved. So thank you. And thank you to all of you that tuned in today. This was a fantastic discussion, and this is exactly what Interconnected is all about, is bringing issues together, shared issues. And so in the future, if you want to sign up on our website, ruralmn.org, you can sign up for our newsletter and you'll find out about our future interconnected topics. One of our next topics is going to be technology equity, and talking about that in urban and rural circumstances. And we have some other topics that we're milling around as well, talking about local democracy, local elections. And so I just want to thank all of you for being a part of this today. And again, this will be posted on our Center for Rural Policy and Development YouTube channel, so you can check that out on Monday. Thank you again so much for everyone participating. If you do have any questions, please let us know. But otherwise, get outside and enjoy the great day. Thank you.